Good morning, everyone. I wish I could be there in person, but I'm on the sideline here at football for college Case Western Spartans going against the St. Vincent Pittsburgh team. So hopefully we'll have a good day. So I appreciate the opportunity to speak. I'm just going to go through some rehab principles with respect to the foot and ankle in particular, and some of the newer ways we're trying to treat some injuries that athletes tend to get. Just going to find my pointer. So the importance of foot and ankle injuries, about 25% of your volume in the clinic is related to sports injuries to the foot and ankle, more commonly basketball, volleyball, soccer, running, and ballet. And can be quite a devastating injury sometimes to elite athletes. It can be out for 2 months, particularly with lateral ankle sprains or particularly with syndesmotic sprains. So really having the proper functional rehabilitation program is really important to really maximize outcomes and get the athletes back to play. So when you're doing an evaluation, you have to discuss with the athlete their impairment and what they're feeling functionally that's limiting to them. And you have to do a thorough physical and history exam. Differential diagnosis is generated, and you try to elicit what the athlete's goals are. Do they want to play further along in their career? Are they looking to retire? Is their senior year? Is it not their senior year? And so a real good partner for us are the physical therapists, along with our athletic trainers that work with the athletes a lot and establish rapport. And so it really helps us figure out what their goals are, and also helps us set goals for athletes. So an athlete that has a good plan and a good goal is going to be more likely to reach that goal. And also the social support that comes from, former athletes themselves who are now physical therapists and athletic trainers really helps guide the athlete through the recovery process. So when we're doing our evaluation, you want to look at the foot type. Are there any deformities, any skin issues, swelling, range of motion, strength deficits, limb length issues, balance, gait changes, sensory changes, and movement dysfunction is a big one to determine what patterns of movement that may predispose them to getting injured again and what we need to correct to prevent that from happening. So foot type, you want to do it in a weight-bearing position. Remember, the hip can actually affect how the ankle works. So excessive pronation, you can get stress syndromes of the medial distal tibia. You can get proximal Achilles tendinopathy. A high-arched foot is less flexible and doesn't shock absorb very well. And so they can get a lot of lateral overload issues, including recurrent ankle sprains, stress fractures, and tendonitis of the Achilles particularly. And you also want to look at the shoe. Unfortunately, shoes are a big problem with respect to some of our athletes, particularly soccer players that tend to wear shoes that are about 2 sizes too small so they can feel the ball better, but unfortunately it can cause some foot trouble. And remember, the shoe prescription doesn't necessarily depend on the alignment 100%. It's also how they are mechanically running. And so you have to take that into consideration when you're trying to either suggest a pronation control type of running shoe. And also when you're doing your movement dysfunction evaluation, you want to look at the entire kinetic chain. So when you immobilize a foot and ankle, you get mechanisms of compensation above or proximal to the ankle. And so we need to address those. And also you have to make sure that the knee and hip aren't contributing to the foot having to be in a bad position when it's functioning. So for example, athletes that have a super flat foot have weak abductors of the hip, and they tend to have patellofemoral issues also. So you really have to start from proximal to distal to correct and maximize outcomes. So plan of care determines prognosis. There's some treatment interventions that you tailor to the particular condition the athlete has. It can go from electrotherapeutic modalities to physical agents, manual therapy, orthotics. Neuromuscular reeducation is a big one. And it really depends on the status of the healing tissues at that time. You do not want to overload the tissues early on because that'll lead to failure. Compliance also is very important for the recovery, and setting realistic expectations and outcomes also very important. So the healing process phases that you have to take into account when you're rehabbing an ankle or foot injury. The initial process is inflammation. So you really are trying to prepare the area for repair and healing. You don't want to ice it too much or too little. It's a very fine line. You want to control the inflammation and the swelling to try to get the motion going in the joint. Electrical stimulation also is a very good modality to decrease pain. The second phase is fibroblastic or proliferative. That's when the collagen fibers are starting to be assembled and laid down. The margin of the wound closes well. The scar or the new healing tissue is still mechanically weak. And so you want to do gentle range of motion and not overload the healing tissue. Manual therapy is very important and helpful in this stage to try to get motion going I'll show you just some illustrated pictures. And also isometric lower load strengthening exercises are also very important. The remodeling phase is the final phase, and it takes up to a year to fully remodel. The scar matures, it gets stronger. The orientation of collagen fibers is actually parallel to the lines of stress and or function, how it functions. And so that's the time that you really start the strengthening exercises. Interestingly, with Achilles tendinopathy issues, they actually found some help with laser plus eccentric strengthening, which is rare to find that in the literature of laser helping. So this is one study that actually did show pretty good result with respect to pain relief and function. Electrical stimulation, you're basically trying to get more effective and efficient muscle recruitment, strengthen some healthy muscle and get back to normal firing patterns. And also swelling gets reduced once those muscles are working properly and more normal girth. Manual therapy techniques are also important. Friction massage, you're trying to change the structure of the tissue so that there's no adherent tissue, things glide or move properly between fascial planes. Also, it can also spur on a healing response. In the situation of Achilles tendinopathy, it helps that tendon heal, trying to spur it on to heal all the way. Capsular stretching also is very important. So exercise progression, a recovering athlete, so it's always a balance between not giving it too much force, but getting enough force so that you can get the strength gains and range of motion gains that you need. So once you do the initial part of your rehab, you start introducing weight bearing, you start looking at the gaits and balance, and then start doing cross training type activities like cardio training and other things to improve overall health, but also get the athlete conditioned. So the usual progression and how we look at rehabbing an athlete back to play, you start first with the non-weight bearing exercises, then you progress that over time. Stationary bike or elliptical or pool exercises are a great modality to really work on that cardio training, get the range of motion going, and also you're loading the muscles in a lower load. And so you can do more in the pool, for instance, doing aqua jogging with a flotation device around the waist is a nice way to get people jogging in the pool. Once you get that and you get good balance, you can start some walking program, and then you do balance training on an uneven surface or unstable surface, and then start the walk, jog, and jogging program. And then you start doing the more complicated things like backpedaling, zigzag running, plyometrics, or power development type exercises. And then finally, we do functional testing to see if the athlete indeed is ready to go back to their sport. Functional testing, there's different protocols. These are just some examples of things that we can do. You always want to check the uninvolved versus the involved limb. So you do the hop jump test, single legs, 4 square hops, vertical jump, or some things you can do. You can do excursion tests just to see how they're lining up functionally when they're doing the exercises, seeing how the range of motion is going with the hip and knee. And you do strength tests like the single leg squat is a very simple one that you could do in the clinic with very minimal space. And you want to make sure that the athlete can do a single leg squat without having any dynamic knee valgus. You want to make sure they're not dropping their pelvis. You want to make sure their hips are even. That means glute medius is functioning properly and supporting the leg properly. It's a very easy test to do, and I do a lot in the clinic to see if they're getting toward the path of being ready, since I don't have a lot of room to have them sprint up and down the hallway. So functional tests, you can do the stork test, which is one-legged stand, and see how long they can hold it side to side, which can be kind of fun if you put them on a uneven surface or wobbly board, or if you put on a airdyne mat that's unstable and they have to grip. You want to do that test with them barefooted because it's much more difficult because they have to use their intrinsic muscles. There's also a formal functional movement screen you can do. The bilateral deep squat, the hurdle step, inline lunge are very popular and very good to really see how the athlete is doing the exercises and make sure their posture, positioning is A-okay, so you can progress them to more difficult exercises. And not only does the athlete have to be physically ready, you also have to make sure the athlete's psychologically ready to get back to their sport. You want to have normal motion, strength is pretty close to normal, and good body posture and control. So that's key to prevent re-injury. So going on to some of the most common things that you'll see is the ankle sprain. So the low ankle sprain is a very common injury. It's number one. So you'll definitely see it. It's an inversion injury generally involving the anterior talofibular ligament. Grade 3 sprains can be quite devastating. It can be up to 20 to 30% of patients might have chronic problems or instability from a grade 3 or complete tear. And so ankle sprains are not benign. If you look actually long-term, 6 months down the road, most patients will still have some sort of muscle fatigue or muscle strength issues. So they have not fully recovered. And so we really need to treat these well. This is just a nice picture of the anterior talofibular ligament that's tight and slight plantar flexion. You have the calcaneofibular ligament, which is also involved at times, and it prevents inversion in the neutral position. So on exam, do a positive drawer test, or you can do a Talar tilt to determine the CFL if it's intact or not. So normally, most acute sprains can be treated non-operatively. It is not proper now to cast people after an ankle sprain. It leads to not good collagen fiber formation, and it makes the tissue very weak. So we want to immobilize them enough so they can start the rehab, but not too much to prevent healing. So motion is really important for new blood supply to the area, and also fibroblast recruitment to put down the collagen fibers. So again, in a cadet study at the military academy, 6 months after a sprain, 40% still had symptoms. And so again, ankle sprains aren't necessarily benign. So when we're trying to rehab the ankle sprain, you have to address different things. One is strength. So the peroneal muscle group is particularly one that we need to retrain. If we don't retrain the brevis to fire properly, you're going to tend to keep rolling your ankle or inverting it. You also want to work on the hips, particularly the gluteus medius, to make sure you have frontal plane muscle control. And then the proprioception deficits have to be reversed. And so that's timing and sequencing, very important. And then once you have good healing tissue, you can do higher level activities such as lateral movement, balancing, rotation, cutting, twisting. So these will be the ladder drills, the hop tests, and things like that. Bracing can be used to try to help with some of the proprioception and also athlete confidence. But really, our goal is to get them out of the brace and make sure that they have appropriate muscle neuromuscular control. So these are just some pictures from Dr. Andrews' rehabilitation book, just showing what the fibular mobilization to try to move the ankle up and down. The second picture at the top center is a distraction maneuver to try to help improve dorsiflexion. There's some soleus pumps, there's some TheraBand pictures. So the key to really strengthening the peroneus brevis is to actually have the foot plantar flexed as you evert. That really isolates the brevis best. If you have the patient do it with it dorsiflexed, you're just going to mostly activate the anterior tibialis tendon instead. So you really have to have that plantar flex position. And these are some more advanced exercises where you have to do some balance training, either on a disc, Aerodyne disc, or you have TheraBands attached to the wall, and they have to control their body, hip, and core as they do the exercises. And that's really tough, and it keeps the athlete on their toes. And then if it gets too easy for them, we just add them throwing a ball against the wall. And so we make it quite challenging. And then to the right is a picture of a hop and jump sequence that you can do to see how they're doing with their lateral movements, up and down, side to side. And so postural control is really important. And actually, people who have chronic ankle sprains do lose some of that supraspinal motor control. And so they develop these mechanisms of compensation that have to be reversed. So you really have to integrate the foot and ankle with the hip and core musculature to really address that. And then if they have structural abnormalities that need to be corrected to get the foot in a better position, we can certainly do that with orthotics. So regaining speed and intensity of movement is extremely important for the athlete. So plyometric exercises are for that power generation, fast, repetitive movements, muscle loading. It's really important for strength performance. And then finally, there's sport-specific training, which is the last part of rehab that really tries to focus on what the athlete needs to do for their particular sport and try to mimic in a progressive fashion how to get them back to sport. So for a pitcher, for instance, we would start having them throw against the wall and then start moving back. And then we have them do a half lunge, throw against the wall. Then we have them stand one-legged in their pitching position with the knee up in a marching stance in the first phase of throwing, and have them balance on a rubber mat and see if they can control that throwing against the wall. And so you can see how you can progress back into the sport that they're doing by a stepwise fashion. For the ankle, for a soccer player, for instance, you would have them, do some footwork with the ball first, do some balancing, kicking, and then switching sides, lateral movements, ladders, drills, all that kind of thing. So each athlete has a different, gymnast is going to have a different functional need than a soccer player. So with chronic ankle instability, you can still do very well functional rehab, and there was a good meta-analysis that examined this, and they found that improved dynamic postural control was achieved, along with the athletes felt more confident and comfortable with their outcomes, that they could play and not be worried about their ankle. And also it reduced the sprain risk down the road. But there's still actually a lot of studies are still small, so there's definitely work to be done. But second common thing that we see is Achilles rupture, and there's been some advancements in how this is rehabilitated, and so I thought I would go through this quickly. So spontaneous ruptures are pretty common, usually eccentric type contraction, particularly basketball, and it generally ruptures about 3 to 4 centimeters proximal to the attachment point. Thompson test is utilized, so side-to-side comparison. So using your index finger, you can feel a defect on the left picture up top. And the Thompson test, when you squeeze the calf, you have no active plantar flexion. And so you know the tendon is not happy. So the treatment, historically, we used to cast them, but they had a very high rupture rate. And so that's why surgical intervention was initially recommended for all ruptures, or most of them. The newer functional rehabilitation programs actually have the latest literature suggest almost nearly equal outcomes in non-operative versus operative treatment. However, in most athletic populations, due to the loss of plantar flexion strength that we see with non-operative treatments, we do still recommend for most athletes that we repair the tendon because they require much more physical activities than you would just regular day life or just a recreational athlete. The sural nerve injury has not been found true with respect to percutaneous repairs. And so the percutaneous repairs that we do are now through a very small incision. And so it limits the amount of incision, so it heals better and also heals faster and less infection rate. So the management, sometimes you cannot do surgery because of, the patient's function or expectations don't really require it, or they have other medical problems and they just can't have the surgery done. The surgical repair, again, usually an athlete is recommended. So the Achilles rupture functional protocol, there's a Glasberg protocol, the gap knot, very, very nicely named. And there's certain patients that fit the non-operative criteria, which would be a complete mid-substance rupture. You catch it early. The protocol is quite intense, and so they have to be able to comply with the protocol. And it'll be ideal if you can treat within the first 7 days. And so at follow-up at different weeks, the physician would assess for filling of the defect and side-to-side comparison of the length of the tendon. You do this with the patient prone, so you can examine the Achilles tendons directly. So this is just the protocol I wrote out. For the first 2 weeks, basically it's immobilization with non-weight bearing in a plantar flex position to decrease load or stress on the repair site. You start doing a walking boot with heel lifts at 2 to 4 weeks. You don't want to dorsiflex past neutral, as that will put stress on the tendon. You can try some early cardio rehab, non-weight bearing. The issue with the tendon is it can be at risk for elongation up to 3 months, so you really have to avoid hyperdorsiflexion. And so as you progress through the protocol, by week 6 to 8, you're 100% weight bearing. You're trying to do removal of the heel lifts. You're trying to do more increased difficulty resistance bands, and you start weight bearing cardio. So as you can see, it takes a long time to recover, and also to do the protocol is quite intense. Once you get to week 12 to 16, then you start to do lunges. You have to avoid lunges and squats until about the 16th week. But again, very controlled, not hyperdorsiflexing. Sports training can start initiating at weight 16, but again, it takes about a year really for these athletes to recover. 6 to 9 months, they're pretty good, but they're really not quite ready to return to play per most studies that actually check how the athletes feel on their function. It takes about a year. Tendinopathy is also a big deal with the Achilles. Most of it is proximal in the 51% position. And eccentric training has been very helpful, particularly for the proximal type. Insertional, not as much, but basically these are some exercise options with respect to progressing the eccentric training, going from just seated heel lifts to doing on a stair or on a elevated surface. And so you gradually increase the load to the tendon to spur on it to heal and make good tissue. Another new option now is blood flow restriction therapy. Ben Galecta will be talking about that further. It's been shown to be safe, and it's a newer option that still needs some evidence, but it's actually seems to be beneficial in a few ways, which we'll discuss. So you can really achieve high training loads without loading the healing tissue, which is excellent because the problem is that we're always facing is muscle atrophy, and it's hard to train the athlete hard enough for them to develop enough muscle because you don't want to stress the healing tissues too much because it could rupture your repair. So this is it's actually came to be in Japan in the 1990s. They first talked about this type of therapy. So you place an inflatable cuff, you have to create a hypoxic environment with exercise, and there's different mechanisms they think it may work, either by hormonal release of growth hormone, lactate accumulation, but basically the muscle protein synthesis gets upregulated. And so you can do low stimulus to gain muscle without overloading your tissues. So this is just some examples of what it looks like. You have to get to about 80% occlusion rate on the artery. Once that's done, then you can do your exercising. So the first stage of application would be to do 80% for 5 minutes and then release for 5 minutes. And you can repeat that with deflation in between. And so it depends on the stage of rehab. So initially, if active range of motion is allowed, you can start the BFR with a TheraBand and work on plantar flexion and dorsiflexion. And then if partial weight bearing is allowed, then you can actually use a plate where you can push against, kind of like a leg press machine. And you can add that without overloading your muscle or tendon. The second stage, you can actually walk with the BFR device on.